Welcome to the UNC Core Center for Clinical Research Speaker Series. We appreciate you joining us for today's talk. Our presenter today is Dr. Jonathan Berg, a professor in the Department of Genetics and the director of the UNC Program for Precision Medicine and Healthcare at UNC. His presentation today is titled Advancing Precision Medicine and Healthcare at UNC. Dr. Berg, whenever you're ready to start, feel free.
Great. Thank you so much for inviting me. I am looking forward to the opportunity to just, tell you a little bit about what the program has been doing in the past year or two. And hopefully towards the end, we'll have a nice discussion about what overlaps there are, how we can work together and so forth. So I'm just going to start with kind of a big picture overview of what I think the field envisions precision medicine to entail. And this is from a 2014 review, so it's a little bit dated, but it was actually at a time when we were calling this individualized medicine. I think the field has evolved what we call things, but it's all the same. It's really the same thing, and that is, leveraging all of the types of data that we have about people, both individuals, but also in large populations, to be able to provide the most precise healthcare that we can. And I'll say from the outset that I don't necessarily think that precision medicine is anything different than the way that doctors have been practicing medicine for decades or even centuries. It's just that the tools that we have are getting better and better. So when the stethoscope was first discovered, that was precision medicine because it gave a whole new insight into the heart. When the X-ray was discovered, that gave us a whole new insight. And so we're just continually adding to the types of information that we have about patients. And I think this graphic kind of represents that, where, from my perspective as a geneticist and a genome scientist, the genome there is kind of core. It's right in the middle. It's the instructions for life, as we say. But the genome is really giving the template for what becomes the transcriptome and the proteome. And those components actually can be just as predictive as the genome itself. So there may be times when looking at specific analytes is actually a better marker than a gene variant. Moving from the outside and the things that we're exposed to and how those affect the epigenome and the control of the gene expression profiles, and how our bodies interact with our own microbiome and so forth, I think are parts of the basic science discovery that will go into precision medicine. And then on the other side of the graph, we see things like biosensors and imaging, which are sort of being put out as the next way to gain a massive amount of data for patients to be able to leverage for their healthcare. And of course, things like social determinants of health, and just combining all of this data in a computational matrix of some kind, whether that's machine learning, artificial intelligence, et cetera, should lead us to a more advanced form of healthcare. And this is, I think, the vision that the field has, and we're obviously still in the infancy of trying to figure out exactly how to implement a lot of it. So at UNC, we envision the Program for Precision Medicine and Healthcare as kind of being a hub or a link for the precision medicine efforts that are going to be happening naturally across all of the School of Medicine departments and centers. And so we would like to be able to be interacting with any group that has a precision medicine effort, so that we have the ability to make connections between groups where there's maybe a shared challenge, or groups need infrastructure that would help multiple efforts. And that's the sort of thing that the PPMH should be able to help with. The other thing that we're doing is serving as a link to other schools at UNC, such as the School of Pharmacy and the School of Public Health, who also have precision medicine efforts, as well as the undergraduate campus and the Office of Research, which has an even bigger picture view of precision health and society. So some of the priorities of the PPMH, and this has evolved a little bit over time, we really wanted to mirror the clinical research and education mission of the School of Medicine. We have been working actively to facilitate the use of genetic and genomic data in the electronic health record, and I will show you some slides about that. We are working on several fronts to enable precision diagnostics, screening, and management. At this point, mostly based on genomics, but there are certainly things that we're interested in doing with regard to predictive modeling and decision support analytics that would happen via electronic health record data. On the research side, we spent quite a lot of time initially looking at biobanking and cohort development and how a centralized effort might be able to help with that. The short story on biobanking at UNC is just that we still are, sort of needing a bigger degree of institutional support for things like core biobanking and the real sort of heavy duty facilities and computational tools that are going to be needed for a large biobank. So we have not pursued that any further. But we've actively pursued providing genomic analysis and disclosure of clinically relevant findings for people who are doing clinical sequencing or research sequencing of genomes that would like to be able to provide that information to their research participants, as well as collaborating with clinical groups on kind of how we can take undiagnosed disease patients, help with diagnosis, and then lend that towards basic science discovery. And on the educational front, we are actively developing sort of educational modules that could be used for different types of learners, workshops on genomic analysis and EHR analytics, and symposia that we're providing for various topics in precision health. So that's kind of the broad picture of what we're working on. With regard to the genetic and genomic data in EPIC, I think most people would agree that the current handling of genetic test data in most EHRs, including EPIC, is really not meeting the full potential of what that genetic information could provide. And I say that because most of the time a genetic test result comes back to the electronic health record as a PDF file or just as a human readable file that, clinicians can look at and see what it means, but it makes it very difficult to think about how to either query the EHR for genetic testing results or implement any kind of decision support. So this, limitation that the reports become stored as PDF files really has hampered our efforts to do quality improvement for genetic testing or just, again, like I said, the decision support. So we believe that by addressing this in a unified way across UNC Health, we can actually improve quality of care, and we can leverage the expertise that we have here in the medical center to add value. And when we're thinking about this as a healthcare system approach, this means that we can really move genetics out into the various health system entities to improve test utilization, enable things like population management, which I'll talk about on a subsequent slide, facilitate sharing of results so that we don't have wasteful or duplicative testing, and so that physicians can know what testing has been done. And then I think as an important secondary benefit, enhancing the research capabilities for those of us on campus who would be interested in looking at, for example, the structured data in the Carolina Data Warehouse for Health. So we worked with ISD to implement the EPIC Genomics module, which is a optional add-on for EPIC that went live in July of this past summer. And essentially what the genomics module does is it has these kind of, two main components to it. One of them, and I'll start at the bottom, is the VAR file, which essentially is a way of representing genetic variants that have been observed in testing. So every patient could have a VAR file that would list basically all of the genetic variants that they've been found to have. And those discrete data can then be used to drive genomic indicators, which I'll talk about in more detail, which are essentially a form of genetic problem lists or decision support tools. So this would, I think, really help us to structure the results that we're getting on patients so that it can improve their patient care and research. The genomic indicator itself is, it's a bit like a problem list in the sense that we can attach this genomic indicator to the medical record that can then be viewed by various providers. And it can contain generic information about that genetic condition. It can also allow providers to make some specific comments regarding that patient and what their symptoms are or what their management plan is. So it can essentially provide a way to communicate about genetic findings across providers. This will allow us to implement decision support tools. So things like active decision support when a physician is prescribing a medication, if there happens to be, for example, a pharmacogenomic finding that would indicate a different drug or a different dose should be prescribed. It can also allow us to drive decision support passively so that a provider could obtain additional information if they needed that. Right now, the EPIC genomics module is not optimal for somatic variants, so the types of variation that we would pick up in a tumor sample, but those are things that EPIC is working on, and I think by being one of the early adopters of the genomics module, it actually gives us a way to influence the way that EPIC develops those tools. So essentially, if you sort of think about it visually, you'll have a provider and a patient who are obtaining some type of lab testing. That testing can be done internally at UNC, and there are some genetic tests that are done here at McClendon Labs, but I think most tests are actually being done as send out, so we have an external result interface. We are actively working with several of the commercial vendors who do a lot of genetic testing for patients at UNC to be able to obtain their results as a digital file that's not just a PDF, but actually structured data, so that both of those types of results can then be directly entered into a variant of our file. So we have a working group called Variant Entry and Genomic Indicator Translation that is working on how to get genetic results into a VAR file. And then the VAR files then essentially go into a tool called the Genomic Translation Engine, which is a component of the genomics module. And this Genomic Translation Engine is essentially is an empty page that we as UNC can develop ourselves. So EPIC doesn't necessarily provide a whole lot of decision support within the genomics module. We build it ourselves, and so that gives us the opportunity to say, for a given genetic finding, how would we like that that genomic indicator to look? Would we like it to generate active decision support for providers? Would we like it to just provide information? Would we like to be able to generate data analysis for population management? And how would we want those data to be represented in the my chart? So again, there are a number of decision-making points, and so the Genomic Indicators Usage Working Group is really a collaboration between ISD and clinicians who have the sort of domain knowledge about how a given test needs to be used, so that we can design the genomic indicators appropriately. And so ideally, those genomic indicators then go back to the chart where they can be viewed by the provider and potentially by the patient. Clearly involved in all of this is the UNC health system and the various entity stakeholders. And so there's a whole sort of additional level of discussion besides what can we do or what should we do that gets to sort of how does the healthcare system really want to utilize this information. So just a couple of examples of genomics module content. So with pharmacogenomics, I think most people are probably aware that there are genes that encode enzymes that metabolize various compounds, and they could be toxins or they could be medications. And one example is the CYP2C19 gene, where certain variations in that enzyme affect the metabolism of drugs like clopidogrel. And so if you have a situation like percutaneous coronary intervention, where you're entering a stent into the coronary artery, occlusion of that stent after surgery can happen when the clopidogrel therapy is ineffective. And so for people who are poor metabolizers of clopidogrel and don't metabolize it into the active form, they can have a higher rate of really severe outcomes. And so that lower graph is showing for people who have poor metabolizer, which is in that red line, so essentially the loss of function for clopidogrel metabolism, they have a very high rate of postoperative essentially rethrombosis of the stent, and that can really include severe outcomes, including death. And so what we'd like to be able to do is identify people at risk for those severe outcomes, put them onto a more effective alternative therapy, such as prasugrel, which doesn't go through the same metabolic pathway, and to have that information available as soon after prescription as possible, and to make that information available as an active decision support to providers. So we collaborated with ISD and cardiology, as well as our colleagues in pharmacy, to implement this decision support in EPIC. Now, it was we benefited from the fact that there had already been ongoing efforts by folks like Craig Lee and George Stouffer, who are the sort of authors of this paper, to develop this decision support at UNC. And so we were able to easily take that work that had already been done and convert it into the genomics module. So another example would be population management of individuals with hereditary conditions. And so, for example, in familial hypercholesterolemia, which affects about 1 in 250 individuals, there's an inherited predisposition to developing hypercholesterolemia, and those individuals have a substantially increased risk of cardiovascular disease and early heart attack. So there's very good evidence that if you diagnose and treat those patients early, that you can improve their outcomes quite dramatically. And so when you think about that, then it really becomes imperative to identify family members of those who have tested positive so that they can benefit from the early treatment with statins. And so the sort of the family tree on the side of the slide here is sort of demonstrating how many people could benefit from cascade testing through a multiple generation pedigree, where there may be, dozens of people potentially at risk. So the EHR ideally should be able to be used to identify at-risk individuals through basic parameters like their cholesterol levels or other personal history, early onset heart disease, and so forth. Ensure that they've had genetic testing, and then deliver that as decision support to providers about the importance of cascade testing. So one of the things that we've done is in collaboration with the Adult Genetics Clinic and the Familial Hypercholesterolemia Clinic, is really to try to optimize genetic testing for patients and their family members, really using the tools that are existing in the genomics module. And then the third example I'll give is tumor molecular profiling, and I think everyone is probably aware that at this point in time, most of the tumors have some element of actionable findings in sequencing. That's not to say that every individual person with a given tumor will have an actionable finding, but just the rate of discovery of various molecular findings in cancer has been quite dramatic over the last decade. One example is in tumors that have a DNA mismatch repair deficiency due to somatic mutations of certain genes involved in DNA damage repair. They can actually develop thousands of somatic mutations in their tumors. And those mutations end up leading to immunogenic proteins. So these are proteins that the immune system hasn't seen before, because they create a slightly different conformation than the native protein that immune system is used to seeing. And those immunogenic proteins then can be more susceptible to things like immune checkpoint inhibitors. And so there's an example of a paper on the right about PD-1 blockade in tumors with mismatch repair deficiency, where the individuals who are mismatch repair deficient can actually have much better progression-free survival when treated with PD-1 blockade. So this is an example of wanting to be able to convert a PDF, sort of a physician-readable result regarding mismatch deficiency, to something that's more digital, that could drive the decision support to ensure that patients are being treated accordingly. The other thing about mismatch repair deficiency is that people with Lynch syndrome, which is a hereditary cancer syndrome that affects about 1 in 400 people, those individuals do end up having a higher rate of mismatch repair deficient cancers. And so even just having a mismatch repair deficiency type tumor might be suggestive of Lynch syndrome, and we could use that somatic tumor testing to improve the rate of genetic testing for those patients, to identify people who have a germline inherited cancer risk that might both improve their management, then also identify at-risk family members who could benefit from early screening. So we have a nice collaboration with Lineberger and ISD, as well as the commercial vendor Tempus, to help us modernize the handling of tumor sequencing results and convert from a human readable form to a digital form that could then drive this type of decision support. So switching gears, I'll talk a little bit about another initiative that the PPMH has really been working hard on, which is an effort, it's, broadly speaking, precision genomic screening. And the idea here is that probably 1 to 3% of the population has a high penetrance, clinically actionable condition that would have a onset in adulthood. So these would be largely the things that I mentioned before: hypercholesterolemia, hereditary cancer predisposition, and so forth. And if we were able to identify people with those conditions before they started to develop symptoms of disease, then we'd have a good opportunity to improve their outcomes. So we are building on a research study that was conducted at UNC a number of years ago called Gene Screen, that was led by Gail Henderson and Jim Evans in the Center for Genomics and Society. And so we're now taking that the results of that study and using them to inform essentially an early pilot of a clinical test that will be paid for by the PPMH. So the patients will not pay for the genetic testing. And we anticipate rolling this out to about 1,000 patients in the healthcare system, really as a clinical offering. Now, there will be some very interesting opportunities to study the uptake of that and the sort of the perspectives of patients who do undertake that testing that we plan to build on top of that clinical test offering. So if you just think about that 3% of individuals that have rare genetic variants that would be preventable or treatable before symptoms develop, that could be as many as 200,000 adults in the state of North Carolina. Thinking about how the UNC health system can reach out into communities that may have lower access to the types of care that we're used to here at the UNC Medical Center, I think it gives us an opportunity to really democratize the way that genetic testing is done and make this available much more broadly than it currently is. So there was sort of a white paper, discussion paper from a National Academy of Medicine Genomics Roundtable group. This group really looked at all the options for implementing genomics-based screening programs for healthy adults. And they are suggesting that we should start with what are called CDC Tier 1 genes, which are genes that have been defined by the CDC as potentially having the strongest evidence for clinical implementation at this time. And so they include the hereditary breast and ovarian cancer genes, Lynch syndrome genes, and familial hypercholesterolemia. So some of the clinical considerations that came out in this manuscript were things like, how do you select patients for this? Are there different age groups that may benefit? So certainly people who are tested earlier in their, say, 20s and 30s will have time to benefit from preventive care, but even individuals who are tested later in their 40s, 50s, and 60s may have family members, like children or younger siblings, who could benefit from cascade testing. So there are many considerations when you think about whether this should be restricted to certain age groups or not. What would be the requirements for informed consent for patients to undergo this type of screening? How would the results be disclosed and interpreted? And then how would one make management recommendations to providers? And then there's also the ethical considerations, and certainly our group has been very attuned to things like the possible psychosocial harms of genetic testing, the potential for genetic discrimination, whether that's through difficulty obtaining life insurance or even pre-existing conditions which are currently protected. That these are the types of considerations that we need to be thinking about when we implement these types of things. The other component of this discussion paper really dealt with things like, is this something that's best implemented at a provider level, so that maybe a early adopter provider tests their panel of patients with these types of things? Or is this something that healthcare systems really should be thinking about implementing more broadly to avoid biases into who is offered this testing? So this has been a guide to how we've developed our program. I mean, I think there is a very strong clinical rationale for genomic screening at UNC. I think that there's a great emphasis at UNC on health promotion and preventive medicine, which this would fall squarely within. I think it gives us an opportunity to talk about family history with our patients and how screening works and what are the pros and cons of screening. It certainly allows high-risk patients to receive advanced management for their condition. Presumably will enable us to save lives, although that's a study that would require a large number of people to be able to prove that that's the case. And I think with the cost of genetic testing for these conditions now really dropping, it gives us an opportunity to provide cost-effective care. So as an added benefit to doing this, we will be able to then enroll patients who undergo this testing into longitudinal studies to really understand the patients' and providers' responses to genomic screening, understanding the natural history of these disorders by really looking at what happens when you identify patients based on a genotype as opposed to identifying them because of a phenotype. This will also really let us look at the outcomes of management programs, whether healthcare utilization goes up, and what the overall impact is on the society. So our first plan, and this is something that we really worked on for the first 2 years of the program, was to implement a process whereby the UNC family practice providers would be able to order this testing during one of the patient's annual health and wellness visit. So this would be an optional thing for patients to be able to have that would be really driven by the family practitioner, the primary care provider. And we had planned to work with several of the UNC clinics to try to capture differences in urban versus rural and demographic diversity. And we actually went so far in February of 2020, had a very nice interaction with the family practice department, which had a lot of good questions, great discussion. And then about 2 or 3 weeks later, everything changed with COVID. And so our plan to really roll this out in primary care clinics had to really be refactored a little bit. So plan B is now to think about a UNC Health Precision Genomic Screen that's offered directly to patients who are being seen in the UNC healthcare system. So our plan is to do this free genomic sequencing of these conditions in the CDC Tier 1, and for the PPMH team to provide the end-to-end support, such as the patient outreach and educational materials, promotional work, genetic counseling at the time of testing if needed, providing the results in EPIC to the providers, and also disclosure to the patients via the PPMH genetic counselor, and then for us to provide the standard management plans to the patients and providers for those who test positive, and to try to make this a more programmatic delivery of this service from the PPMH. And the goal really long-term would be to enable any patient in the UNC healthcare system to have access to genomic screening. So once we've kind of conducted our 1,000-person trial pilot implementation, we'll need to look at how we can make this available to the rest of the healthcare system. So I'll switch gears now, talk about precision diagnostics. And so this is now thinking about how to use the sort of advanced types of testing, primarily genetic and genomic testing, in ways that will allow us to reach more patients, to utilize this testing most efficiently, and to really start examining, in some ways through a research effort, how other types of omics tests might be useful for diagnosis and management. So we've worked with the McClendon Laboratory genetic counselor, Tom Felton, who's really, his main mission is to think about genetic test utilization and to help providers to most effectively do this testing, whether that means referral to a specialist or whether that's a facilitated genetic testing strategy, sort of depends on the situation. We would also like to see research be embedded in this diagnostic analysis in a more dedicated way. So I think there are lots of opportunities for sort of N of one type evaluations where there may be a patient with a rare undiagnosed disease, so that those types of patients can get genetic testing that will give us the best opportunity to identify a molecular cause. And that would be either through clinical testing supported by the PPMH, or by research testing that can be done on campus with exome or genome sequencing. We've also been collaborating with the Department of Pediatrics to initialize a undiagnosed disease clinic for pediatrics. And you may be aware that there's an NIH network called the Undiagnosed Disease Network, which has a number of sites across the country, including one just down the road in our dark blue friends healthcare system. And we would really like to be able to be offering the same types of opportunities to patients in the UNC health system who have essentially an undiagnosed disease. So by starting with pediatrics, we'll be offering research sequencing to those patients and other types of omic testing I just mentioned, to give us the ability to identify their molecular cause of their disease. This will be coupled with a registry for longitudinal follow-up of these patients, including their detailed phenotypic information and clinical information. We'll be able to utilize machine learning tools that have already been developed on campus to think about how to leverage the phenotypic information with the genotype information to facilitate a diagnosis, and then to translate that directly to basic science when we have discoveries that implicate a particular gene, to try to identify people on campus who might be interested in following that up, either with animal models or other basic science approaches. And then really long-term, one would like to turn this into a system where the diagnosis in the patient may lead to basic science discoveries, but then also to translational drug discovery and development. And so even working with the School of Pharmacy on how to sort of take these diagnoses and move them into a pipeline where candidate drugs might be able to be tested on patient cells or other types of materials to give us the best opportunity for targeted therapy. So this is a very early effort. It was also hampered to some extent by COVID, but we're looking forward to moving into this undiagnosed disease clinic soon. The other thing that we are providing as a research, almost a research core, I hesitate to call it, it's not an official UNC core yet, but it's something that we're very interested in sort of thinking about how we can implement. But we are offering it as a service to researchers, which is to say, whenever a research participant is having genomic sequencing, it is now, I think, standard of practice to offer some form of disclosure of clinically relevant findings. And we'd really like to be able to provide that core resource for researchers. We have a pipeline that's been built over the course of several research projects that my group has been involved in, which includes the genomic sequencing, the bioinformatics, and the analysis of those genetic variants for both the primary diagnostic analysis, but also looking for secondary findings that might be medically actionable, but unrelated to the reason that person was sequenced, as well as confirmation in the CLIA lab at UNC and clinical reporting and disclosure. So we have this existing pipeline that's been built over the past 10 years, and PPMH will make it available to researchers who are doing exome or genome sequencing in their patients. We would like to make it as flexible as possible so that if the sequencing has already been done, that we can skip ahead to the bioinformatics step. If the variants have already been called and it's just a matter of analyzing them, we'll be able to take the variants and run them through the molecular analysis process. So essentially, at whatever level a researcher has data, we should be able to help facilitate that. And obviously, an important component of this is that appropriate consent is obtained in the research study. And so we also have a genetic counselor working with our group who will help researchers develop IRB language for both the protocol and the consent forms so that this analysis and disclosure can be done. Another substantial effort, which is ongoing at this time is to really think about how we can leverage the electronic health record and all of the data within it in a sort of virtual cycle, or what's called a deep learning healthcare system. In a sense, taking the data that's existing in the healthcare record on millions of data points from patients across multiple time points, and using artificial intelligence and machine learning to help develop decision support. The challenges here is that this is really inherently collaborative effort. We need the experts in EHR data, for example, Emily Pfaff's group at NC Tracks, to collaborate with biostats and machine learning experts who really know how to crunch the numbers, informed by what is needed by the clinicians, right? And what is the clinical question that needs to be answered or addressed, so that we can get the right decision support to the providers. There are also, I think, a need to be collaborating within the UNC health system and the health informatics groups that are really, responsible for Epic and how that data is used clinically, and collaborators like Renzi, who are very interested in sort of how one could develop pipelines for generating this kind of decision support. And the key problem is, how do you sort of wrangle all of the data? And it's all quite different in terms of its structure. Some of it's highly structured, some of it's very unstructured, like clinical notes and things like that. The image data is often not there, and so you just have a clinical report from a radiologist. Pathology data is really distilled down to a clinical report, but some of that's structured and some is not. And so this is a big data wrangling problem, to be able to get things into a structure that can really be used by the computational tools. And the other part of this is an implementation problem, and that is, what types of decision support do providers want, and how will they react to it? If it's a black box that's generating some recommendations, will that be the sort of information that a provider will be comfortable using? And so there's a lot of angles to this that we're interested in looking at. So we need these multidisciplinary teams with the clinical driver, the biostats experts, EHR data experts, and programmers. And our goal here, or our approach, has been to really think about different clinical use cases that we can identify the clinical champions for, and then to try to pair those clinical champions up with the technical folks. Corbin Jones, who's a member of the PPMH steering committee, has been really heading up our effort to develop these types of use cases. One of them, just to give an example, would be, for example, management options for specific conditions like postpartum hemorrhage, where if there are predictors that might give you an indication that a patient is at higher risk for postpartum hemorrhage, would there be some type of decision support that could be provided in the obstetric care that would improve those outcomes? COVID obviously presents a large number of potential, data, essentially lots of data, but also the potential for machine learning and improved care. But it's an extremely complex case, and the healthcare system already has, to some extent, the analytics that are driving some of the questions in COVID care. And so some of the question we have to have is, what are the pain points that the healthcare system has that we can help with, and what are the pain points they have that we really can't? So again, the COVID sort of jumps in and derails some of the things that we're interested in. But I think long term, building a culture at UNC where we can be thinking about how to take basic science discoveries and these advanced analytics and really incorporate them into clinical care is something that we need to be working towards. So the last couple of slides, we'll talk about outreach and education. We've done a lot of networking with departments and entities on campus to try to look for opportunities to collaborate. Lineberger, Thurston, neuroscience, et cetera, pharmacy. Really, I think the key here is identifying shared interests and working together. We've also been developing modules for trainees. So I'll show you a little bit about a summer program on health informatics that we worked with the School of Information and Library Sciences on. We're also developing an EHR data analysis workshop that might be amenable to residents and fellows who are interested in starting to learn how to do some of this work. We've collaborated with other folks on campus to provide educational content, such as invited speakers or other types of webinars and presentations. And we've also developed a couple of symposia of our own. The summer program that we just worked with the SILs on really, again, in response to COVID, these were meant to be on-campus programs where students would come to campus and either engage in EHR type analytics or health informatics with the HiDive program, or on-campus research through the SURF program. And so PPMH created essentially a summer program for career exploration in precision medicine that would be offered to the students whose summer programs had been affected by COVID. And this ended up being a 6-week virtual program. We had opportunities for the students to learn about the various careers that are important in genomic medicine and precision medicine, ranging from clinical genetics to health informatics to ethical, legal, and social implications, to really get them to engage with some of the folks on campus who have had these careers and what it entailed. And some of those have been actually recorded as podcasts that are available on our website. Again, we had a pretty wide range of faculty members who participated in this, which was nice for the patients to be able to get a broad range of interests. The other few things that we're doing, we've been involved in a DNA Day curriculum development grant, working with NC Tracks to develop educational materials about some of the tools that they've developed for EHR analysis. Again, mentioned the collaboration with SILs on a training workshop for EHR data analysis that's in progress and hopefully be rolled out soon. And then we are involved in collaborations on a R25 diversity action plan, which is a type of grant to enhance the pipeline of students that are interested in genomic and precision medicine careers. And then on the right, I show an example of a mini symposium that we held over the summer, which was a kind of pharmacogenomics and cancer-focused symposium. And we have another mini symposium coming up that will focus on health disparities and how precision medicine may both potentially exacerbate, but hopefully address health disparities. We've also been providing research support through matching funds for the TRACS pilot awards, which has been a successful program, and we're looking forward to seeing how those supported grants are doing, including one from the Thurston Center. So I'll end there. Be happy to take any questions that you may have had about the existing programs or future programs, or how we might collaborate on things that you all are doing.
So just to remind everybody, you can either unmute yourself and ask the question, or type your question in the chat box and I will ask it.
Thanks, Jonathan. That was a great talk. A lot of exciting things that are going on. I'm really trying to think, and maybe we can just brainstorm on how the CCCR might interact more with your group. And the presentation you gave was pretty genetics oriented. Right. And right now we don't have a lot of genetic information in arthritis, autoimmune diseases that's at the point where we could use it for precision medicine. So I don't know if you have any thoughts about what we could do to be involved in some of this.
Yeah, I mean, I think I would point to some of the other types of data that might be more closer to the phenotype, right? So I don't know the extent to which epigenetics or microbiome, whether there are things that you think play a role in rheumatological disorders where we could do a better job of trying to leverage that information. Some of it is not quite ready for clinical care yet. And that's so, a lot of the things that we focused on were really how do we kind of improve the, clinical informatics for genomic data and things like that. But you know, I think through research, I think we're very interested in the types of basic science research that can lead to implementable testing, whether it's screening people for increased risk or whether it's you know, the types of therapies that might have a pharmacogenomic, you know, that there may be an enzyme that affects whether someone responds well, so forth. So, you know, we're definitely interested in any kind of collaboration. It doesn't have to involve specifically genetic information. You know, I think there's a lot of potential for kind of the EHR analytics and decision support that may overlap a little bit with the sorts of things that you all are interested in.
Right, right. Yeah, you mentioned the microbiome. We are doing some work in that area now. And we have some projects that are just getting off the ground that are more genetics, genomics, trying to identify sort of the causal variants that are important in development of osteoarthritis. There are a lot of known variants that are connected with OA risk, but which ones are causal aren't known. So we're working with Doug Fanstill and others to develop a project in that area. So we're still, at the basic level, we're still sort of not quite close to what you know would be something that could be implemented.
Still in discovery phase for sure. Yeah.
Yeah.
So Dr. Nelson also has a question. Would you like to ask it, Dr. Nelson?
Great, thank you. You mentioned earlier in regards to PATH reports about sort of the text-based clinician level kind of report and the lack of sort of quantifiable data that can be pulled from that. We have the same problem with imaging in that the OA codes in an EHR are really poor and infrequently used and don't really capture probably the extent of disease that we might be able to get at if we could determine osteoarthritis from, say, an imaging report. And I'm sure that's not an isolated sort of area. So I wondered if there's any efforts toward imaging reports and how to sort of make those into usable data.
Yeah, I mean, it's a great, I think my general feeling is that just about anything that we're doing in healthcare that could be converted to discrete data, as opposed to, you know, the usual, what we all do, right? Which is, you know, write out a clinic note or dictate a clinic note, right? And, you know, we need to move towards structured data because that will give us the best hope of identifying these things. If there's a specific type of collaboration that we can think about working with radiology on, I'd be very interested in doing that, you know, and sort of how can we, part of it is sort of a sociological phenomenon, right? How do you convince a radiologist that what they should do is change the way that they document things into some kind of structured field? In pathology, they have, it's largely being driven by the American College of Pathologists. So for tumors now, they have specific, I'm forgetting the name of them. Anyway, they're basically structured forms that the pathologists are supposed to fill out, and it's basically a quality measure now. And so if you get if you get a college or you know, a major body saying this is a quality issue, you have to do it this way, and your reimbursement will depend on you doing it this way. You know, then obviously we'll see all of it change, right? Then people will be documenting things in structured fashion. But for right now, we may just have to convince our colleagues that there are certain things that would be useful, and maybe it's sort of how do we take baby steps? Are there certain features in a you know, radiology report that could be structured in a way that would allow us to at least pull them out of the you know, the electronic health record or the CDWH with text mining, right? So even if there were structured, you know, fields that could be used in a dot phrase, for example, one could pull those sorts of things out of the EHR a little bit more easily. So what, is there something specific that you could think of that would give you a better way to, I mean, is it a matter of finding people in the EHR who have OA or other features that, we could sort of do a pilot project on?
Yeah, so I think, one of the challenges we face in doing EHR work with OA is that it's just not coded well, because usually that's not the primary reason for the visit, or, maybe they talked about it with their doctor, but it wasn't really, it wasn't coded, like their diabetes and their hypertension were coded, but their osteoarthritis wasn't. And so we use those codes in a similar way to what we do with like RA or lupus, but they're just not nearly as specific and sensitive as they are for some of our other diseases. And so the thought was that a lot of those people do have x-rays, and you could either confirm the coding or potentially identify additional cases, sort of like you do with medications, right? You say, well, do they have a code of diabetes, or have they been on, diabetes medications for 3 out of the last 6 months or something like that? It would be a way to get at people that might have OA that it's not really being talked about in their visit, perhaps.
Yeah, so I think this kind of verges into an area of digital phenotyping, which is to say, can you build a set of features from EHR structured data, whether it's ICD coding or CPT coding, or just other sort of patterns of care that a person might have had, that would allow you to identify them as potentially being at risk to have that condition. It may not be a perfect predictor. It may have, some, false positives and false negatives, but I think the extent to which we can start building those tools would allow you to at least screen patients who might have OA. And if the predictor were good enough to provide that information to primary care providers that would then say, this patient may have OA based on these features, you could consider doing X, Y, and Z. One example of a project like that on campus that I can't take credit for, it's not a PPMH project, but is, I think, really emblematic of this, is Mike Knowles and his group in pulmonary have been looking at how to identify patients who might have the kind of primary ciliary dyskinesia type condition. So this is a lung disease where they're susceptible to infections and so forth. And they've been working to develop a predictor of PCD. Can we then use that to pull those patients out of the EHR and get genetic testing done to identify the people who do truly have that rare condition? I think it's that sort of thing that we need to be, as a whole field, be working towards. What are the computable phenotypes that might be predictive of one condition or another, and then developing the procedures for communicating that information to providers, and then getting the next steps taken, whether that's a diagnostic test or some other, what is the next step for that? So in any case, I think we'd be very interested in, if you have some specific ideas in mind, we should talk more about it. Any other questions? Oh, got one more chat, I see. Oh, thank you.
Yeah, thanks. I think you've given us a lot to think about, and we could get back together as a group. We're working on a grant called a Center of Research Translation, where we want to get more of the omics type data, the genetic data, and so it may be that if we do get that and we make progress, that we'll be ready to work more with you in this type of project in the coming years.
Sure.
Yeah.
Well, let us know if there's anything that we can do to help out with that grant.
Yeah. Thanks again for coming and talk to us.
Yes, thank you, Dr. Berg, for taking the time to talk to all of us today. So we're going to be sending a follow-up email in the coming days with a link to access the recording of this talk in case you would like to listen to it again or share it with your colleagues. I'm also going to include the PPMH link so you can learn more about what Dr. Berg and his team are working on in this field at UNC. And so what I'm going to do is I'm going to stop the recording, and then I'm going to start the poll. Again, if everybody could fill it out prior to leaving, that'd be really great to get some feedback on how everybody thought the presentation went. But thank you again for attending.